here on Aboriginal land. I also acknowledge and pay my respects to Aboriginal elders, past and present, and extend that respect to Aboriginal people here today. Welcome all. I'm Chandra Jendra, Professor of Medicine at UNSW, and I'm also Director of the Gastrointestinal Viral Oncology Group based at the Ingham Institute. I'm a gastroenterologist by trade, and I've got a couple of speakers today to kickstart the Bankstown Hospital presentation. It's essentially work on esophageal cancer and the discovery of high-risk human papillomavirus, predominantly genotype 16 and 18, as a cause. I used to say association. I stopped using the word association, but I truly believe it's a cause of a subset. The operative word is subset of esophageal, of Barrett's dysplasia and esophageal adenocarcinoma. And that subset at the moment, as we speak, constitutes 25% of all esophageal adenocarcinomas. And the operative word here being adenocarcinoma, not squamous. That's a totally different ball game altogether. So I'd like to get one of my senior registrars, Dr. Kostas Brooks, who's also doing a higher degree, a PhD with my group, who will present data on human papillomavirus and Barrett's dysplasia in esophageal adenocarcinoma, and how we got there. What were the original thought processes that went through our heads to get the kind of studies going? Although I must acknowledge the great part played by some of the patients, particularly one lady who really kind of gave us some of the impetus and the research questions, which we as doctors never thought about, which is absolutely fantastic. That's one of the beauties of being involved in research. You learn from everyone. And I think I've learned most from my patients, and I think a lot of us have. I think I've got a couple more minutes. And I haven't got a lot more to say, and I think I should turn the podium over to Dr. Kostas Brooks, who's a gastroenterology and hepatology fellow at Bankstown Hospital. He completed his studies at UNSW and he undertook advanced training in gastroenterology at Prince of Wales. And he's got a keen interest in cancer detection and surveillance, both therapeutic and palliative interventions. And he's been with us for the last almost 2 years, and he's undertaking research with our group as well. And also I'd like to mention briefly now, although I will talk a bit more about our guest speaker, Professor Krish Ragunath. He's a very well-known international speaker on Barrett's esophagus. I know Krish from some long time ago. Krish actually was Professor of Gastroenterology at the Queen's Medical Centre in Nottingham, and he was also part of the committee, British Society of Gastroenterology Committee member. He's an active member and come up with a lot of the guidelines published in Gut. And he's also on the World Endoscopy Organization Research Committee, and he's done lots of papers and publications. But I'll come to him a little bit later, and he'll be talking to us about Barrett's esophagus in general. So Kostas, I can see you're online, and I'm giving you an extra 2 minutes for your presentation. It's all yours.
Okay, hello, can you hear me? Hello, can you hear me?
Yes, can hear you, Kostas.
Yeah, fantastic. Thank you so much, Sean, for that very lovely introduction. And I will share my screen and get this rolling. Okay. Okay, here we go. Sorry for the delay. Okay, so thank you for the presentation and opportunity to present at the meeting. And I'd like to start firstly by introduction. The introduction has been made. And I want to acknowledge the traditional custodians of the land, the Daruk and the Ora people, and pay respects to the elders past and present. As you said, my name is Dr. Kostas Brooks, and I'm here at Bankstown Hospital, and I've been working with Shah Majendra and his group of the GI Viral Oncology Group at the Ingham Institute of Applied Medical Research. Today, we're looking at the causal link of HPV and Barrett's esophagus and adenocarcinoma. Are we there yet? Let's take a step back and talk about when I'm trying to prove causality, we need to demonstrate firstly a good strength of association, good consistent replication of the similar results, include specificity and temporality of results. We need to show almost a dose response and a biological gradient, as well as having a proven biological mechanism, or at least biological plausibility to the hypothesis. And finally, and most importantly, experimentation showing adequate results and consistent results. The overview of the talk will be going through 6 pieces of work that we've been doing, part of emphasizing this hypothesis and try to convince you that it may be a bit closer to proving it's an etiological factor in some esophageal malignancies. Firstly, I'll be talking about the link between HPV and esophageal adenocarcinoma and pre-malignant lesions. Talking secondarily about the detection of transcriptionally active HPV being associated with Barrett's dysplasia and malignancy, as well as viral load and traditionally active or high risk HPV integration early into host genome being associated with disease severity. And 4th and 5th, viral persistence post-endoscopic therapy of Barrett's dysplasia. And 5th, showing clinical outcomes with 5th being looking at the genome of the esophageal adenocarcinomas, whether they had HPV infection or not. And finally, looking at survival benefits. And firstly, let's take a step back and talk about esophageal cancer, which is the 6th leading cause of cancer-related deaths worldwide, with over 145,000 Australians diagnosed every year, and worldwide, almost 500,000 people diagnosed or more. Previously, prior to the 1960s and 70s, this was characterized by a squamous cell carcinoma. However, the patients still presented and still currently present late in their disease process, often with a third with distant metastatic disease and quite a poor survival. There has been, in the last 40 years, almost an epidemic of esophageal adenocarcinoma in Western countries, including the United States and Sweden. Similarly, we also noticed that there's been an epidemic, a similar increase in patients with head and neck squamous cell carcinoma. So far, the only pre-malignant precursor lesion for esophageal adenocarcinoma has been Barrett's esophagus. But we've noted in our epidemiological studies over the past few years, many tens of 20s of years, we've gotten better at looking at the Barrett's esophagus, better at finding changes, but really the malignancy risk has been downgraded from 0.13% to 0.12% per annum. So what is the driving factor in the last 34 years? What are we missing? Is it high rates of reflux? Is it high rates of obesity? Is it something in the diet? Are we treating H. pylori better? And this is causing these malignancies to predate. What else? There has to be something else. It's just too big an increase to ignore. As you can see on the epidemiological studies here done out of the United States, we've got a reduction in this SCC, 1985, and a subsequent huge increase in adenocarcinoma rates. We published it in the Therapeutic Advanced Gastroenterology Journal with Pratik Sharma, a prominent researcher at Barrett's esophagus and esophageal disease in the United States. And with no plausible reason for this exponential rise in just Barrett's, there must be something we're missing. And one of the identified possible factors could have been viruses or a viral vector. Our analogy we've taken, as I said, in head and neck squamous cell malignancies since the 70s, there's been a huge increase in HPV associated or HPV positive tonsillar squamous cell carcinoma and a relative decline or plateauing of HPV negative carcinoma. So the hypothesis behind HPV infecting these kind of transitional epithelial layers, whether they be in the head and neck or whether they be in the cervix, is at the transformation zone or at the transitional zone, there some sort of microabrasion occurs on the left-hand side, and viral particles are able to penetrate down to the basal layer of cells. There, the basal layer leads to chronic infection. Infection leads to mutation, which I'm about to tell you about. Mutation leads to dysplasia. Dysplasia leads to malignancy, as you can see on the right side of this slide for cervical cancer. The cellular pathways, bottom left-hand corner of this screen, you can see the standard cell cycle. The main two proteins that drive cell cycle arrest and apoptosis to prevent malignancy have been P53 as well as RPB. So that's retinoblastoma protein. HPV, in transcriptionally active HPV or high-risk HPV, you get production of a specific viral protein called E6, which binds to P53 and impairs apoptosis, and similarly E7, which also binds to retinoblaster protein, which also has a pro-malignancy or dysplastic effect, or at least puts the cells in a state of constant replication, leading to further mutations. This hypothesis, this group published on the hypothesis whether or not we can draw analogies from our neighboring transitional zones, and we can take that to esophageal adenocarcinoma and Barrett's dysplasia. At that time, a thorough literature review was done. There were a few groups around the world who investigated HPV, esophageal adenocarcinoma and Barrett's esophagus, but primarily these studies were small. They didn't use nested PCR or fresh tissue. They were mainly retrospective studies, and they didn't look at any clinical outcomes. So the significance was relatively negligible. They also included low-risk HPV genotypes without even looking for evidence of viral replication, and they were from throughout the world, you know, Western countries, Eastern countries, South America, etc. So we published our landmark study from our group in 2013 in the American Journal of Gastroenterology, where we looked specifically at transcriptionally active HPV being associated with Barrett's dysplasia and esophageal adenocarcinoma as part of our Barrett's esophagus group here. This is a prospective cross-sectional study of 261 patients who both controls as well as patients along the pathway from squamous to metaplastic to dysplastic to adenocarcinoma pathway. We biopsied the transformation zone as well as the lesion. We took both fresh frozen as well as formalin fixed specimens. In these specimens, we looked at the fresh frozen for nested PCR of the HPV DNA to prove presence of the virus. Also, we looked at viral P6-INK4A, which is a marker of active viral replication, so a high risk or transcriptionally active HPV in the paraffin embedded stains, as you can see there in the bottom right-hand corner. The bottom left-hand corner illustrates our PCR looking for HPV DNA presence. We also used real-time PCR at the time to look for E6 and E7 mRNA in the fresh frozen, which once again proves a virologically active replication of the HPV virus. At the time, we were able to find that 1/3 of the patients who were recruited had positive HPV DNA in their specimens, and the majority were HPV 16, 18 genotypes, the high-risk genotypes in cervical cancer. And these are more likely to be seen in severe disease, with a viral presence mainly at the junction as opposed to the lesion. As you can see here, the combined controls had about an 18 to 20% prevalence of HPV DNA detected, and in the Barrett's dysplasia and esophageal adenocarcinoma group is up to 2/3, being 68 or 66%. Similarly, P6-INK4A, which is P16-INK4A, sign of transcriptionally active HPV, can be seen in 44% of those with dysplasia and cancer compared to 2 to 3% of controls. Then we break this subgroup down to see of the strength of association based upon not only the detection of the HPV PCR, but also of these biomarkers, whether they be P16 or E6 or E7 that were positive. As you can see here on the left-hand side, the orange graph show that of the subset of 261, 78 were positive with the SCJ. Of those, 38 were positive PCR of HPV. Of those, 16 were positive for P16, and also 4 were positive for E6 and E7. If you are positive for the HPV virus and positive for P16 and positive for the active viral genes, so the active viral proteins, E6 and E7, your odds ratio of having advanced disease, whether that be Barrett's dysplasia or esophageal adenocarcinoma, was 103, which is as high as is seen in patients who have chronic, uncontrolled, or poorly controlled reflux with Barrett's esophagus. The next step we want to ascertain is was there any association between increasing viral load disease severity along the Barrett's esophagus, Barrett's dysplasia, and OAC pathway? Was the HPV integrated early into the host genome? And did that have any benefit or any significance? And finally, with increased integration, was there an increase of disease severity seen? So next slide, we looked at the prevalence of HPV-16, HPV-18 genotype. Predominantly those with Barrett's dysplasia had the HPV-16, which is consistent with in other fields of cervical cancer and head and neck malignancies, often presenting with a more severe, with more chance of having a malignant process or dysplasia. Then we looked at whether the viral load or integration status affected these, what subgroup they would fall into. Control groups, you can see very little amounts of HPV detected, and mainly it was found mixed or around the or episomally. As you progress into Barrett's dysplastic group here, and also the EAC group, you find that the viral genes are more mixed, or found more so mixed with the nucleus, and also a very high number of viral loads being seen compared to control patients. Here's a lovely picture we took comparing our detection of the HPV virus in Barrett's esophagus. So in the top left-hand corner, as you can, I don't know if you can appreciate with the arrows, the little black dots are the HPV detected in the basal cells of the esophageal columnar tissue. In the top right-hand corner, in the Barrett's dysplastic tissue, you can see it again, as well, a bit more evident in the bottom left-hand corner, all those black dots surrounding the glands, and the right-hand side in the esophageal adenocarcinoma. The next slide is a picture of, this is the area I'm talking about in terms of the transitional zone. On the left-hand side, you see the squamous cell epithelium. On the right-hand side, you see the columnar epithelium of the Barrett's esophagus. There is a tendency for the HPV to only be found within the glands of the Barrett's esophagus cuboidal or columnar tissue, which then goes to support the hypothesis why these patients are getting esophageal adenocarcinoma, as opposed to, as I said, the previous cohorts having squamous cell carcinoma. So from these studies, we concluded that for the first time we've demonstrated that transcriptionally active high-risk HPV is strongly associated with Barrett's dysplasia and OAC, but not just the presence of Barrett's without dysplasia. Viral infections are seen in the esophagus, so they tend to be focal at the junction, transformation zone, and a significant association between higher viral loads and disease severity, and also the increased integration to the host genome is happened early and tends to be more prevalent as the disease progresses. The next step we want to look at in cervical cancer, they looked at the persistence of HPV after loop excision of the cervix or surgery to the cervix for high-risk lesions. They found that if the HPV persisted after local excision, then these patients tend to do poorly and have increased rates of recurrence. In our group here, we propose a trial in our Barrett's patients once they have been diagnosed with Barrett's dysplasia or with high-risk features or carcinoma in situ. Once they're treated for the carcinoma with resection, with endoscopic resection, they often go into an RFA protocol. So they include seeing the patients for endoscopy 0, 3, 6, 9, and 12 months. And at individual times, we go about using the RFA, which is an ablation thermal technique, to ablate all the esophageal mucosa, all the Barrett's esophageal mucosa, and change to a squamous non-neoplastic form. And each time we enrolled patients for both fresh frozen biopsies as well as formalin fixed tissues, and we did it at baseline 3, 6, 9, and 12. The purpose of this study was both to look at patient-related outcomes, whether we had in these future cases complete eradication of dysplasia, complete eradication of intestinal metaplasia, which is thought of to be a precursor to esophageal dysplasia, Barrett's dysplasia, whether the patients who in different groups had persistent disease or not, whether there was recurrence. Also, we looked at the biomarkers and the viral clearance associated with endoscopic therapy. So here's a summary of the study that we did. We recruited 43 patients with 3 loss to follow-up. 15 patients were prior to testing positive for biologically active HPV. Of those 15, after endoscopic ablation, 13 were no longer HPV positive, and 2 of them continued to have HPV. Those that continued to have HPV, of those, 2 of them progressed to have either Barrett's dysplasia detected on further biopsies or esophageal adenocarcinoma. As you can see, in this middle group where the patients had P53 positive but no HPV, those that had P53 persistence also went on to continue to have Barrett's dysplasia and OAC. But for us, This study identified there is a subgroup of patients who, upon endoscopic treatment, lose their HPV infection. And once they've lost their HPV infection, none of those patients went on to have any esophageal dysplasia or, Barrett's dysplasia or esophageal malignancy. The only one subset of those, one patient ended up having P53 on repeat testing, which is a different mutation. Here are some pictures when I'm describing what we're talking about, these viral oncoproteins, E6 and E7. Top two pictures, A and B, are evidence in cervical cancer in the pink, and also in head and neck cancer in the pink spots as well. And we've seen those similar outcomes in our biopsies of HPV positive patients with both esophageal adenocarcinoma and Barrett's dysplasia seen in slides C, D, and E. And it tends to be very, be persistently in the glandular tissue, as I previously discussed. Here's an image that was published in the International Journal of Cancer in 2017, which I think displays it the best. If you can appreciate here, there's pink colored cells, which are the columnar mucosa or columnar epithelium, and amongst the pink covered areas, there's little pink dots. Those little pink dots are the HPV virions that are infected or that are infecting the cells, indicating to us a form of viral tropism. The virus tends to go specifically for these cells, which explains what's happening. From these studies, we concluded that most HPV-infected Barrett's dysplasia and OAC patients cleared the infection with endotherapy with a rate of up to over 85%. Persistence or progression of dysplasia and neoplasia after endotherapy for Barrett's esophagus was associated with either HPV persistence or ongoing P53 overexpression. P53 overexpression is independent from the HPV positivity, and other HPV malignancies exhibit similar molecular aberrations. So then we went on again, drawing from hypotheses from the head and neck surgeons, as well as the cervical cancer patients, whether or not the HPV positive cancers actually had different genetic mutational landscapes compared to the HPV negative malignancies. Of this, we looked at fresh frozen specimens for patients 12 fresh frozen specimens, patients had treatment-naive resected esophageal adenocarcinoma samples. And after that, 4 were the HPV positive and 8 were the HPV negative groups. This is our presentation of the data from that. We saw on the left-hand side, B, D, F, and H. These are the HPV positive OAC group. Had a total number of reduced total mutations at 1.31 compared to the HPV negative that predominantly had 2.56 mutations per, and this was clinically significant. And this was clinically significant. So we do think, much like the other malignancies, we're dealing with a different type of malignancy to explain why it's behaving differently. We then went on to assess whether or not there were other factors at play, whether or not it's just HPV or whether there are other factors or mutations at play. And so we looked at, similar to other studies in cervical cancer and head and neck malignancies, whether other biomarkers, including PRB, retinoblastoma protein, P53 or cyclin D1, were associated with different stages of the pathway. And this we looked at both fresh frozen specimens and formalin fixed specimens. As you can see in this picture, this picture is meant to show the data we collected and looking at the biological mechanisms and the strength of association. The images highlighted in red. I want to draw you to table 4, which is the association of the protein markers and marker combinations in HPV DNA and RNA positive Barrett's dysplasia and esophageal adenocarcinoma. First image, I think the first line which I've highlighted there, if you have P16 high, so these people are transcriptionally active HPV, but your retinoblastoma protein was low, and your P53 was low. And if this combination was present, you had an OR of having just an odds ratio of having progression or having malignancy of about 55.6% with a fairly good specificity and an average sensitivity of 50%. Similarly, if you look to the table 3, the table listed above, you can see if your P16 is high and your P53 is low, the sensitivity and specificity was 85%, 61% with an odds ratio of 18. But this is another way we've kind of shown that the PHPV may be driving the process, more so than these other factors. So we thought this was all very interesting data in the lab and very interesting data, at least preliminarily, but we need to really show these data affecting patients, try and guide whether or not HPV needs to be incorporated into the clinical model of care, and whether or not HPV detection and eradication in the future is of clinical significance, as it has become in cervical malignancy and head and neck cancers. So we did a study looking at survival rates for patients with Barrett's high-grade dysplasia and esophageal adenocarcinoma with or without HPV infection. Of these patients recruited, we noted that there was a difference in their disease-free survival, is whether or not they had HPV or whether or not they were HPV negative. And that was statistically significant with a p-value of 0.02. Then we looked at overall survival, and again, we saw that statistically significant difference of a p-value of 0.06. We then wanted to see whether or not is it just the HPV or does transcriptionality or the fact that they're transcriptionally active impact these kind of survival scores or survival difference. So here we separated transcriptionally active and non-transcriptionally active based upon the viral oncoproteins that I discussed before, as well as P16. And you can see the transcriptionally active group did better than the not transcriptionally active with a p-value of 0.02. Overall survival wasn't demonstrated, unfortunately, when comparing the two groups. In terms of brass tacks or the numbers you want to hear, if you have proved from this study of patients that if you had HPV positive high-grade dysplasia or cancer, your disease-free survival was 40 months compared to if you had HPV negative cancer or high-grade dysplasia, your disease-free survival is only 24 months. Overall survival similarly, 43% in the 43 months in the HPV positive group, but only 29 months or 30 months in the HPV negative group. Furthermore, other characteristics, the chance of recurrence or progression, only 24% if you're HPV positive, but almost up to 60% if you're HPV negative. Recurrence alone is also doubled as well, almost tripled, pretty close, almost tripled, or doubled at least, from 16% to 43% in the two groups, as well as the chance of distant metastases occurring being 8% in the HPV positive group and 27% in the HPV negative group. Similarly, there was a difference in deaths seen between the two groups, being 13% in the HPV positive group and 36% in the HPV negative group. Then, based upon other studies happening at the same time in the realms of HPV and malignancies at other parts of the body, we wanted to see, are there any other biomarkers that we're missing that may be associated as well as HPV and their interactions with HPV in terms of survival. We did a following study, which looked again at a similar subset of patients, and we plotted on the graphs here their survival and whether or not they had these proteins. So in the retinoblaster protein, so this is table A, there was no statistically significance outside of the HPV positivity or negativity. In the MCM2, similar. In the Ki67, similar. CD1 was not that obvious, not most affected compared to the other groups, but again, there's just more data to be done on this kind of subgroup. After that process, in the world, as we continue to publish these kind of data in European journals and international journals and international conferences as well, other groups have become interested in this field. There's been some studies out of China with 174 patients with esophageal adenocarcinoma, with them finding 35% patients had HPV. There was a meta-analysis of the European Journal of Gastroenterology showing of 19 studies showing a pooled prevalence of 13%, a lot lower than what we found. Those authors have suggested that the prevalence rate may be affected by small sample size and compromised detection methods. We know of many other groups internationally that we're currently working with in this kind of role, and we're interested to see their outcomes and collaborate with them in the future. In 2014, New England Journal of Medicine published an article looking into Barrett's esophagus and esophageal adenocarcinoma, and the presence of HPV or human papillomavirus was published as a risk factor for esophageal adenocarcinoma in patients with Barrett's esophagus. So the conclusion from this talk is hopefully of all the above data and studies we've done and hypotheses we've made being proven, we've demonstrated an etiological role for high-risk HPV and Barrett's dysplasia and esophageal adenocarcinoma. The presented studies and evidence provide new horizons into Barrett's esophagus and Barrett's esophageal adenocarcinoma research, by the way, providing fuel for future longitudinal, interventional, and molecular studies. Our thoughts in the group as to where our next steps are. Ideally, it'd be nice to in vitro transfect Barrett's cell lines with HPV 16 and 18 and look for whether or not we can detect the steps of malignant change to fully understand in vitro the processes that occur. We're continuing to collect further future data, looking at HPV chronic infection in patients who are recently diagnosed or previously treated with esophageal malignancy and look for evidence of recurrence of dysplasia and malignancy. We're interested in performing whole genomic analysis as opposed to a previous genomic analysis to see if there's other viral expression studies or other proteins that are being expressed that we haven't accounted for that are different between the two subgroups. We'd like to also look at whether or not there's an ability to develop some sort of therapeutic vaccine for HPV, although I think most of our research currently is in COVID, but it'll be interesting as the future evolves also to look at how the vaccination of the population with Gardasil, as is happening in our current generation, will affect future rates of HPV esophageal infection and esophageal cancer. And again, we look forward to publishing data, future data, and working with other groups internationally. So once again, coming to our proof of causality, the group, the Hill group, who provided the original quotation, show that the proof of cause is always elusive, but prudence should reign and action should be taken rather than waiting for more evidence. And we hope to have taken the next few steps forward in trying to gather as much evidence to support this hypothesis, and hopefully work in the future to try and prevent this terrible disease. I'd like to acknowledge my research supervisor, Professor Shyam Rajendra, as well as Shweta Gautam, who's one of the researchers in the lab, as well as the numerous other physicians and surgeons who have, and pathologists who've been instrumental to our work. Thank you.
Thanks, Kostas. Now we've got some time, haven't we? Do we have some questions? I think there was some in the chat group, and there was a question I answered on your behalf, but Kostas, there was a question about, was there a difference or was there any relationship between smoking rates and HPV rates? It was a good question, actually. It's an excellent question.
I'll just look up. I'll have to look up the database to have a look, but I'm not sure at the moment. I'll get back to that at the end.
Okay, the answer was no, and I suspect the premise for that question is if you look at the cancer of the cervix, smoking may be a cofactor in carcinogenesis and HPV, maybe, but we're not sure. And the reason we didn't find, and I don't think the head and neck people either found that as well. And by the way, 70% of all HPV cancer, 70% of all head and neck cancers are now HPV driven. Okay. In 1998, when they first started to do work on HPV and head and neck cancers, and this lady was Maura Gillison at Johns Hopkins, 98. She did a lot of that work. And a lot of people kind of sniggered when she was doing this work. And at that time, it was 25 to 30%, where we are now with the esophageal adenocarcinoma. But who knows, 30, 40 years from now, it may be a lot bigger. But in head and neck cancers as well, I believe the smoking and alcohol is the subgroup now of 30%, and the rest of it, 70% is HPV driven. And the reason for that is because of the P53 mechanism, because smoking knocks off. It actually goes through the P53 mechanism mutation pathway, and HPV is really more an exclusive non-P53 pathway. Any other questions from anyone?
There was a question from Les about what's the prevalence of HPV in people who do not have adenocarcinoma. So I assume you mean in the control samples.
Yeah, you can put up the data. If we go by, if I go by memory, I think you're looking at about 18%. Is that right in controls?
I'm just looking up data as well.
Just give the individual prevalence. There will be about anywhere between 10, 12, 15, no more than 20%. But that's non-transcriptionally active.
Yeah, so, we saw PCR was positive in 18% of the 122 combined controls.
They're not biologically active though.
No, the
So
biologically active was only 3% in the 100 combined controls. So 3 cases out of 104.
Which is predominantly P16, which is an indirect surrogate marker rather than E6, E7 mRNA, which is really the true gold standard. Yeah. Okay. Any other questions? You should have lots of questions, folks. You know, you've got to exhaust us. You've got to challenge us. Any other questions? Fire away. Okay. Now, Krish, I think it's. I don't want to eat into your time, so I've got Krish Ragunath here. I alluded to him a little bit earlier. So Krish is now Professor of Medicine at the Curtin University Medical School. He's a consultant gastroenterologist. He's an interventional endoscopist. He's very good at poems, I know, and many other things. And he's a consultant gastroenterologist at Royal Perth Hospital. I believe that's where Helicobacter pylori was discovered, huh, Krish?
I think so.
Yeah.
Before my times.
Yes. And he's a fellow of the College of Physicians of London and Edinburgh. And he's also chairs the World Endoscopy Organization Research Committee. And he's got many publications to his name, over 150. Okay, Krish, I welcome you to the stage and take it away.
Thank you, Sean. Are you able to see my slides there?
No, not yet.
You're not seeing my slides?
No.
I was sharing it.
Oh.
1 minute. Let me. I shared it before. Let me try and get this Zoom thing up and running. Okay. I need to open it again. 1 second. So you're able to see me, but you're not able to see the slides. Okay.
Yeah.
Okay. Just open it once again. Are you able to see now?
No, I can only see your folders.
But this one should have come up now. Okay, let me again have a look. Where is it? I have shared it. I don't know why it's not coming up. We rehearsed all these things. Suddenly this. Okay, let me share again.
Or do you want to just read it from your?
No, I'm just wondering why I'm not able to share suddenly. I was able to.
Ellie, are you able to help, Ellie, if you're in the audience?
I don't have a copy of the presentation. Did you want to close the screen again and try again, Krish?
It is. Oh, okay. So I think it is sharing the screen, but it's sharing the unopened one. Am I right?
Yeah.
Okay. Let me.
Yeah.
I'll stop share and then reshare it once I get the other one up and running. 1 minute. So, okay. Now we'll try it. So one screen is being shared. I'm sorry about this. We made all this rehearsal.
Yeah.
Are you seeing now?
No.
No. Okay. Okay. So is it not showing up? It's a shame. Okay. Are you seeing now?
Yes. Yes.
Okay.
Finally. Yeah. Absolutely.
I think what I'll do is I'll go now. You're able to see now.
Yes. Excellent. Full screen. Yeah.
Okay. I think we'll keep it like this. Thank you very much for your kind invitation, and thanks for the organizers of the Health Beyond Research and Innovation Showcase 2021, organized by the Ingham Institute and the Southwestern Sydney Local Health District. Thanks for inviting me to give this talk. It was exciting to hear Kostas going through your entire research program, which you had spent almost your lifetime on HPV and Barrett's, and it was quite educative for me as well to hear all the work you've been doing. And what I'm going to do basically is to give a bit of a overview of Barrett's esophagus, a little bit of the epidemiology, and the other issues in Barrett's esophagus, the missing link of why we are not able to reduce the esophageal cancer mortality whilst we are increasingly diagnosing Barrett's. There is more access to endoscopy, advanced techniques, and so on. But surveillance is not simply working because patients with Barrett's are not really dying of Barrett's, they're dying of cardiovascular mortality. But we are not really identifying the ones who are high-risk patients. And that's where your work, the biomarkers and things will come into play. These are my disclosures. Just to recap, Barrett's was originally described by Australian-born British surgeon Norman Barrett in the 1950s, and originally he described this as a congenital short esophagus. But now we know that this is an acquired condition, and it's metaplastic replacement of the squamous epithelium at the gastroesophageal junction in the presence of columnar glands and intestinal metaplasia. And the reason why we are talking about Barrett's is because of its pre-malignant condition and the poor prognosis with esophageal cancer, overall 5-year survival, about 10 to 15%, which has not changed over the years. And I think that's purely because we are diagnosing them late. So these are the changing trends in esophageal cancer. In the 70s and 80s, it was more of squamous, but now you can see that it crisscrossed, and adenocarcinoma is really up there as the most common cause for esophageal cancer. So this is the data from the Cancer Australia showing that the cancer rates for esophageal cancer, adenocarcinoma, is going up. Whilst in the men, whilst in the females, it's almost plateaued off. So still there is, the slope is going up. But this study was from Queensland, looking into the endoscopic diagnosis of Barrett's esophagus. And you can see that if you look into the data here between 1990 and 2002, there is nearly a 9 to 10-fold increase in the diagnosis of Barrett's esophagus. So basically, we are diagnosing a lot of patients with Barrett's esophagus. So how are we diagnosing them? Literally, all these patients are diagnosed with endoscopy because now it is still the gold standard, where you do a good quality white light endoscopy, and then you see this metaplastic replacement. So in this slide, what I'm showing you is the high definition imaging, which has been there for the last decade or so, but now we are moved on into ultra high definition, which is the 4K, which is 4 times the resolution of a high definition. So that's what we're doing. So the imaging is really very good, and we should be able to detect subtle lesions. So we did a comparative study in Nottingham using the high definition, comparing the standard definition. We showed that if you use high definition, there is increased detection of dysplasia. And it is also now well accepted that endoscopic treatment is the treatment of choice for patients who are diagnosed with high-grade dysplasia and early adenocarcinoma. So this was one of the landmark publications from the Wiesbaden group in Germany in gastroenterology, looking into 1,000 patients followed about 5 years, showing a complete response and cure rate over 96%, which is really very good. And there is literally no role for surgery in patients with high-grade dysplasia or early cancer. And you can see that there was zero mortality, procedure-related mortality, and there were very minimal major complications. So the current clinical management of Barrett's with neoplasia is to first resect any visible abnormalities. You can see it's a very subtle abnormality in a long segment of Barrett's. You resect it by endoscopic mucosal resection. And once you've done the endoscopic resection, then you treat the remaining Barrett's with radiofrequency ablation. And there is argon plasma beam as well, and cryotherapy is also around. But I think the gold standard now is radiofrequency ablation. If you do that, you get over 90% dysplasia eradication rates and instrumentplasia eradication rates if it is done in a very good standardized protocol. So that's the current standard of care. Now, looking into the benefits of surveillance, this was a very old study, but this was one of the studies that showed that patients who are diagnosed with esophageal cancer in a surveillance program, if they have treatment, in those days it was surgery, their prognosis is good. Their overall survival is good compared to patients who have been diagnosed with esophageal cancer who are not in a Barrett surveillance program, which means that if a patient comes in the hospital with a dysphagia and they have a surgery and they have Barrett's esophagus, their survival is less compared to someone who has been on the surveillance program. So this is an argument for why we should be doing surveillance. But on the other hand, if you look into what do patients die of, you can see that only about 7% of them are dying of esophageal cancer. So majority of them are dying of something else, primarily cardiovascular comorbidity, because this is the age group we are looking at, the risk factors like being men, middle or elderly age, and smoking. So these are all risk factors for cardiovascular comorbidity as well. So your heart attacks or your strokes kill you before esophageal cancer kills you. So that's what has been happening if you look into the reason for these patients dying. Now, if you look into what is the esophageal cancer mortality rate, is it going down? No, it's not going down. And this study from Rachel Malhado from Birmingham, she showed that still the esophageal cancer mortality rates are going up. So there is really a disconnect what is happening here. You're having esophageal cancer mortality rates going up, but still patients with Barrett's are not dying of esophageal cancer. And if you look into the patients who are having operation for esophageal cancer, only 5% of these patients have prior diagnosis of Barrett's. So there is something missing somewhere here. What is missing here is that for every known patient, we know that patient has got Barrett, there are at least four patients out in the community who are not known to have Barrett's. So these are the high-risk patients who are getting esophageal cancer and they're never coming into Barrett surveillance program. So if you don't come and see you or me or any of the gastroenterologists who are going to be doing the surveillance endoscopies, we're never going to diagnose them early, and they are the ones who end up presenting to the hospitals with cancer. So why are they not coming to attention? The problem here lies is that nearly 40% of them are asymptomatic out in the community. Maybe they're taking up some antacid pills, that's it. And they feel that that is a way of life and they just avoid eating spicy food, thinking that that is the cause for that, and they never come to attention. So these are the patients who tend to, probably tending to develop cancer in the long run. So how are we going to deal with this is the question. So this is the big Barrett's conundrum. So you can see that there is an increase in esophageal cancer. We've shown you there is increase in esophageal cancer mortality as well, but we are not diagnosing really cancers which are curable, and we are increasing diagnosis of benign Barrett's. So we're diagnosing more and more of Barrett, they're all benign Barrett's, but these are not really high-risk patients. So what are we supposed to be doing? Should we be screening for this high-risk group? Who are this high-risk group and how we should be doing screening? So that nicely brings me into the pathophysiology or pathogenesis of acid reflux, bile reflux, the change from metaplasia, dysplasia, and carcinoma. So this is a very standard slide which many people talk about, where you have the normal squamous epithelium, chronic inflammation, ulceration, healing results in Barrett's epithelium, progresses to low-grade dysplasia, high-grade, and cancer. So these are all the risk factors which has been published quite widely. Acid and bile reflux is very well known. Smoking, obesity, male, white race, family history. And now HPV infection is slowly coming up. People are starting to realize that this is also one of the contributing factors. And thanks to your group and a few others who have been working on in this area. So this is a recent Nature's review published a few years ago, where they have put in the odds ratio of all the risk factors. You can see male sex, white race, and presence of GERD symptoms, hiatus hernia, and the waist circumference ratio, smoking, and so on, and the family history. So these are all been put in, but unfortunately, I didn't see that there was any HPV here in this. But as you rightly pointed out, Shan, when you look into up-to-date, you can see that HPV is one of the etiology causes for esophageal cancer. So it is starting to be recognized as because of increasing evidence now coming through. And I think Kostas has already gone through the work, what you've done. One of the first papers showing that there is an association between the transcriptionally active human papillomavirus and Barrett dysplasia and esophageal cancer. And then your group has gone on to show their association of the wild type P53 and aberrations in the protein pathways. And also that patients who have persistent HPV have failed endoscopic ablation and have dysplasia. So that's an interesting point to be observed, because this can be something which will relate to the treatment response. So I think that's an interesting observation. And also, you have shown that patients with high-grade dysplasia and esophageal adenocarcinoma, in fact, have a favorable prognosis. So this is something which we need to take into account as well when we are quoting the prognosis in these patients. So there are quite a few amount of work needs to be done in this area to really tease out where exactly HPV sits in here. Now, we have done a little bit of a preliminary work in Nottingham, which is unpublished data, and it was about 50 patients who had 20 patients who had surgically operated patients with Barrett's and esophageal cancer, where we looked into the tissue specimens using the qPCR, and it showed that about 25% of them were positive for HPV. So this data, where you had a higher positivity rate, and some of them have shown the meta-analysis had shown 13%. We sit somewhere around that 25%. Obviously, the small sample size, this was just a pilot study to see what was our HPV positivity in the UK, in Nottingham. So I think moving forward, if we could move this forward with the further bigger studies from our biobank, then we should be able to get more information of the population prevalence of HPV in the UK in Barrett's patients. Now, let us go into the cellular origins of Barrett's esophagus. So this is quite an exciting area now, because unless we get this right, whatever endoscopic treatment or diagnosis and all the rocket science we are trying to do in advanced imaging is not going to work if we don't hit the right target. So this is a very good review article by John Inadomi, published a couple of years ago, looking into 3 possible ways the Barrett's can originate from. The one is the traditional one, what we've been thinking about is the squamous stem cells present in the submucosal glands, which turns out to become the Barrett's epithelium. The other theory is that these stem cells originate within the columnar glands at the junctional mucosa, and then it turns into a Barrett's glands. And finally, the third one is the one from the normal gastric epithelium, which turns out, which is called the gastric stem cells, which turns out or drives the Barrett's glands here. So these are the different things that has been proposed. And now the most recent publication in Science a few weeks ago from the Rebecca Fisher Cambridge group doing seminal work in this area and showing the molecular phenotyping of Barrett's esophagus and where exactly it is from. So the methods they did was for human esophageal and gastric cardiac tissue samples in normal Barrett's esophagus and cancer patients, and they used a single-cell transcriptomic profiling and in silico lineage tracing, and they also used the somatic mutation analysis and finally functional studies and organoid models. So it was quite a comprehensive work what was done from this group, and it was a multi-center work. So they showed that the epigenetic, genetic, and transcriptional similarity for the Barrett's was similar to the gastric cardia here. And also went on to say that the undifferentiated gastric cells from the cardia give rise to Barrett's epithelium, where transcriptional programs driven by the c-MYC and HNF4A protein oncogenic pathway. So this is something quite new which has come out, and saying that the Barrett's comes really from the cardia, and you don't really need to have a long segment of Barrett's esophagus. You can get an adenocarcinoma even in the absence of visible Barrett's esophagus, but because it has already changed molecularly at the cardia. So this can be one of the reasons why some of the patients who are diagnosed with adenocarcinoma, you don't really see a segment of Barrett's. And people were speculating that the Barrett's cancer has overgrown the Barrett's epithelium. It may not be the case. It might never be that this patient had endoscopically visible Barrett's, but this must have come directly from the cardia. So anyway, this is something which is new, and it's new in the sense that it also relates to how we are treating these patients. Because if you look into, I was just looking into our data, which was published a couple of years ago, and looking into the timeline and location of recurrence following successful ablation of Barrett's in a multi-center study within Nottingham and the Mayo Clinic. We noticed that after you ablate patients and then follow them up, almost all the recurrences are happening at the gastroesophageal junction, and they are invisible as well. So what it means is that ablating the gastroesophageal junction is a key, and you need to ablate the stem cells there, which we don't know whether we should be doing it or not. But in Europe, especially when we started the studies in Amsterdam, we were religiously ablating the gastroesophageal junction. We would ablate the normal Barrett's, and at least 3 or 4 times with the Halo 90 catheter, we will ablate the GOJ. But that has not been the practice universally. For example, in the States, it was not done in the first studies published from the US, but it was done subsequently. So this might be the reason why your recurrences are always in the distal esophagus at the neosquamous epithelium and the cardia. It may be that we are not ablating this. So moving forward, we need to be thinking about how endoscopic treatment can ablate this area if we are going to be following up these patients and treating these patients, and it may give us some more information. Now let us move into the biomarkers and where it is now in clinical practice, because this is an interesting area, and I think our focus more should be in this area. So the P53, which Kostas also mentioned, is very important in the Barrett's metaplasia carcinoma transformation. So this is the 2 pathways, what happens when in the P53 oncogene, tumor suppressor gene. So when there is a P53, this is a traditional pathway where there is P53 inactivation, and then it goes through the various stages of low and high grade dysplasia in the cancer. And the other one is a genome double pathway, which is quite a rapid pathway, where this is one of the reasons where we see patients who are in the surveillance and they would have had an endoscopy about 2 years ago. They come back, you are seeing a slightly more advanced cancer, not just a high grade dysplasia, maybe it is a T1 cancer, and some of them even go to have surgery. So it might be that these are patients who are going to this alternate pathway. So unless we get to the bottom of both these things, again, we are going to be missing out on some of the patients who rapidly progress compared to some patients who remain benign for a long time. Followed on by this, this is a good study from the US group where they looked into the P53 mutations in Barrett's esophagus, and they looked into all the patients who progressed, or not all the patients, a group of patients, a cohort of patients who progressed, and they went into the last 5 years, and then another group, control group, who did not progress, and noted that P53 mutation, even before there is histological changes of dysplasia, had a 13-fold increased progression. So which means that you can risk stratify these patients. When the patient comes for endoscopic surveillance, you can risk stratify using P53 mutation and say that, look, guy, you are not going to get a cancer. Maybe you can come back after 5 years. We'll do a scope, like how you do a colonoscopy polyp surveillance. You go off for 10 years or so. The other one, you come back in a year, come back in 2 years because you have P53 mutation. And along with this, things like HPV will play a role as well to see if it is positive. Then you may risk stratify, come up with a score, combining the epidemiological factors, the male sex, Caucasian race, smoking, obesity, and then put in the equation of P53 HPV. Then you can come up with a scoring system to say risk stratify these patients when you decide on surveillance. Now, finally, I'm going to spend the last few minutes into other advances in the pathological approach. And here is the system pathology, which has been now taken up and there is this group called Ceranostics who has been working on it with the US and the Dutch group. So essentially what they do is they integrate clinical, morphological, quantitative, and molecular parameters using mathematical analytical frameworks. Part of AI is involved in this. Again, it brings in all these things, the morphology, the pathology, the molecular biomarkers, and then come up with the mathematical analysis using AI, and then they come up with a scoring system. So this has been independently validated now and just recently published. And this shows a sensitivity of about close to 70% and specificity of 95%. It's not perfect, but again, this is another movement on how you integrate computational methods, bioinformatics, and biomarkers and the pathology, and then come up with risk stratification in these patients. Now, let me go through a few of the other things which is happening. Unless, as I said, we screen the patients, we identify the patients who are at risk of Barrett's and put them in surveillance, we are not going to be making much difference to the surveillance program, because the patients who are having cancer are not coming into attention. So this is the cytosponge or trefoil factor 4 study, the best 1, best 2, and best 3, which was involved in the US, in the UK, where we have been doing the cytosponge for cytology of the gastrosophageal junction, the Barrett's, and the trefoil factor 3 has been identified as a marker for Barrett's esophagus. So there's a lot of randomized studies have now been done in the UK, and in fact, a pilot has been rolled out in Scotland in patients 50 plus, has had some heartburns and have taken some PPI in the past, have been invited to undergo a cytosponge screening, like how you do a bowel cancer screening. So I think this is one step forward. We looked into the using the cytosponge for patients who come back for post-ablation follow-up. And we've shown that there's a sensitivity of about 74%, specificity 85, accuracy 84%, where you can diagnose recurrence or intestinal metaplasia or even dysplasia in patients who come for Barrett's post-ablation surveillance. So it can be used for screening, it can be used for monitoring as well. Again, we need to validate it in bigger centers and a bigger patient population, but these are all non-endoscopic ways of diagnosing the Barrett's progression. And this is another interesting concept, which is the e-nose or the electronic nose, where you measure the volatile compounds in the breath exhale, and it come up with biomarker signature, and it has shown a reasonable good sensitivity as well. So this has been done both in the Netherlands and the US, and this is around the corner, and I guess we will be seeing more studies coming out of it. And it's very, very non-invasive. It's like your alcohol breath test. It can be done in a primary care. So the cytosponge and e-nose, they're all things that can be done in a primary care to identify high-risk patients. Currently we are working on the oral microbiome signature for Barrett's, and this study was from the US, showing distinctive microbiome signature on oral swabs or salivary samples in patients with the Barrett's compared to the controls, or these are the patients who have reflux. This is again another test which is very, very non-invasive, can be used to identify high-risk patients and then subject them to an endoscopy to identify Barrett's esophagus. Finally, my last slide here is now we are in the omics revolution, the metabolomics, the proteomics, and the lipidomics revolution here. And one of the potential things, biomarkers, is looking into the microRNAs. The exosomal microRNAs contain a molecular cargo here, and a lot of information which is being carried on in the circulating exosomes. Now we have technology to identify circulating exosomes and also do the sequencing here. So this is again an exciting area. It could be liquid biopsy. So we have a technology which we can use as a screening tool for using the breath. You can use it in the cytosponge. You can use it in the oral swabs, and now a blood test. So a combination of these things, certainly at one day we will be doing to identify the high-risk group in the primary care. So this is what I think will happen in the future. We will be identifying target population, and this could be by the risk factors, what I mentioned earlier on, and they use a non-endoscopic screening technique, liquid biopsies, breath testing, oral microbiome, or even cytosponge. And if you identify the Barrett signature, then these patients have a baseline endoscopy and biopsy with the biomarker risk stratification. This is where the HPV will come in as well, along with P53. And if this patient goes into high risk, then you ablate them. You don't want to wait until these patients develop high-grade dysplasia cancer. Then you can say that you are a high-risk group. You go ahead and get it ablated. It's something like removing a polyp in the colon, and then follow them up. And this can be followed up even with a non-endoscopic biomarker, like I showed you the cytosponge, or there might be the exosomal microRNA that can be used as a liquid biopsy to be following up. So the patients where we find none of them are positive, say for example, P53 is negative, there is no dysplasia histologically, and as I showed you, the tissue cipher serologistics doesn't give you a higher score, maybe HPV is negative as well, then these are low risk patients where you can either discharge them or leave them on the higher surveillance, like longer periods of surveillance, for example, 5 years, 10 years, and that will probably make the surveillance more effective, and then also hopefully reach the patients who really need us, rather than the patients who are having benign Barrett's and we just keep surveying them without having an impact on esophageal cancer mortality. So I'm going to leave you with there and be happy to take some questions.
Thank you very much, Krish. Unfortunately, we've run 10 minutes over time. That was wonderful. In regard to the biomarkers, that was fantastic. And we are doing P53 biomarkers regularly in our Barrett's patients, and I think we should be doing them. Don't you think, Krish?
Yes, we have said that in the BSG guidelines, but we're a bit cautious. We didn't go and say that everyone should be doing it, but we said that should be considered. And that, that guidelines was a few years ago. So now things are moved on, and I think it's good that you're doing it. And I think in Australia, we should be doing it.
We should be doing P53, and I actually do P16 as well. But I think we should be doing a bare minimum P53. I can't take any questions now because we run over time, but thank you so much, Professor Ragunath and Dr. Kostas Brooks. Wonderful. I think it was a good presentations from both of you. And we look forward to having more of this down the track. Thank you all.
Thank you very much.
I hope you all enjoyed it, the audience. Thank you. Bye.